the cardiovascular part of the pathology section at MRCS, we're going to cover the aortic stenosis and infective endocarditis. So what are the causes of aortic stenosis? So it usually depends on the patient age. So you have some congenital causes which happen due to bicuspid or unicuspid aortic valve. And there are some senile causes which usually happen in old ages, more than 70 years old. And that will be due to diabetes and hypertension with time. And we're going to explain the pathophysiology as well. And also rheumatic heart disease, which can lead to scarring, and this happens between 30 to 70 years. So if we gonna make like a diagrammatic section to the heart, so if you have like that, and this is the left atrium, it just will be sort of like this, and that will be the left ventricle, and the aorta will be coming out from here like that. All right, this is just a diagrammatic thing. So obviously these are the pulmonary veins. The blood will come from here and then will come here and usually exit through the aorta. So the aortic stenosis is basically you have this valve is bicuspid or unicuspid or congenital or whatever the reason is. You basically have an outflow obstruction. All right, so this is an outflow obstruction of the heart. So that will cause lots of pressure on the wall of the left ventricle, and basically the wall will be working against lots of resistance. Okay, meaning working against lots of resistance, that means increase in the afterload. All right, increase in the afterload against the heart. And due to that working against resistance, the wall will start to get thicker and thicker with time. It's like the muscle is working out for a very long time. So thicker, that means left ventricular hypertrophy. But it will not only get thicker to the outside, it will also get thicker to the inside as well. So the muscle will be sort of like this, right? So that means the lumen, this is the lumen of the left ventricle, has decreased. So decreased lumen, right? So decreased lumen, that means the preload, all right? The preload has decreased as well. So basically what you can see from here, we have three things in the pathophysiology of aortic stenosis. One is left ventricular hypertrophy, two is increase in the afterload, and three is decrease in the preload as well. That obviously will decrease the heart function and the efficiency with time, and it can even lead to heart failure. Also, this load with the left ventricular hypertrophy can lead to increase the demand of the blood to the heart muscle and cause some sort of compression on the coronary arteries, and can even lead to ischemia or myocardial infarction, and that will be the main cause of death in those patients. Again, it can also lead to imbalance in the electricity, and it can lead to arrhythmia as well. Okay, so it can lead to arrhythmia. The patient's symptoms mainly are the word SAD. Okay, so it's basically shortness of breath and angina or chest pain and dyspnea as well. Actually, the S is for syncope, not shortness of breath, which is sudden collapse, and angina and dyspnea as well. So this is just basic explanation of the aortic stenosis. So we mentioned the cause of death, which is mainly myocardial infarction, aortic dissection. There's something called how to calculate the coronary perfusion pressure. It is exactly the same like the cranial perfusion. So we can calculate it by measuring the aortic diastolic pressure minus the left ventricular end diastolic pressure, and this is the coronary perfusion. So looking at this dissection, you can see this is the valve and there. Right, and there is lots of calcification and lipid accumulation on the valve leaflets. This is basically what can cause the stenosis in all what we just mentioned. So we mentioned the scarring is one of the reasons, the calcification and the senility, and diabetic patients and hypertension with hyperlipidemia lead to accumulation of lipid as well. Pathophysiology, we mentioned left ventricular hypertrophy, and we know that this is caused by increased resistance against the left ventricle, and you also have increased myocardial load, and this is basically due to increase the afterload, and decrease the preload due to decrease the lumen size, which we just mentioned as well. Most likely cause of arm weakness and aortic valve endocarditis. So endocarditis, you will have lots of vegetations on the wall. All right, these vegetations exactly like a thrombus. Okay, so these thrombus might start to travel as an impulse anywhere. So if it went to the brain, it will lead to a stroke and can lead to arm weakness. Okay, so arm weakness mostly due to cerebrovascular stroke. You have warfarin is an anticoagulant medication that is called a vitamin K antagonist. Okay, the vitamin K dependent factors are 1973. So factor 10, 9, 7, and 3. Okay, so of the 2 actually, 1972. So these factors are mainly in the extrinsic pathway. So the pathway that will not be affected by the warfarin will be the intrinsic pathway. A thrombus is a solid material formed of blood constituents. The surgical options for valve replacement, we have whether you can use a mechanical valve. So you can use a mechanical valve. So I mean, to be honest, the way you should answer it in the exam is you say we can probably have a mechanical valve, which is durable, can last for very longer duration, and but it's a little bit loud for the patient, causing some sort of noise all the time, even when they are asleep. And there is increased risk of bleeding because the patient will need to be on warfarin for a very long time. And also, obviously, since they are on warfarin, the reason why we're giving them warfarin is because there is increased risk of thromboembolism as well. On the other side, we can have a tissue valve or a prosthetic valve, and these are less durable, they are not loud, and they don't need warfarin or anticoagulation for life. Okay. However, the risks and benefits need to be established based on the patient condition and the patient age as well. So, for example, if you have a very young patient, you will probably need something for them that will last longer and decrease the risk of having another surgery for them. So, mechanical valve could be a better option. However, the tissue valve can be better for an older patient. There is different operations that we can do. The commonest one that is being followed nowadays is the TAVI or the TAVR, the trans-aortic valve replacement. And there is something that is called Bros procedure. Is basically you're taking a healthy valve from somewhere else and putting it under the damaged valve. These are the comparison, and we mentioned it. So you do have a mechanical valve. It's durable, but needs warfarin with risk of bleeding and thromboembolism. On the other side, it doesn't make any noise, and it's not not as durable as the mechanical valve. Doesn't need warfarin, and difficult to insert, and less thromboembolism risk as well. What is the management of infective endocarditis with patients who have metallic valve? So obviously, metallic valve is a foreign body for them. So we'll need to remove this foreign body because it will be a septic focus and it will not be working anyway. What is the cause of microscopic branching hyphae in the removed metallic valve? The way I remember is T came. So T is trichophyton. This is Candida, Aspergillus, Microsporum, and Epidermophyton as well. So this is aortic stenosis. Very quickly on pathophysiology of aortic stenosis and also the complications and the cause of death and so on. Moving forward to infective endocarditis. So infective endocarditis, basically, if this is the heart, this is the endocardium of the heart, as you can see in here. So basically, you do have sort of bacteria that start invading this endocardium and will cause some sort of inflammation to the patient. So it's an inflammation on the endocardial surface. However, it can be infective and non-infective. So infective obviously goes by bacteria, with the commonest organism being Staph aureus, the commonest organism of all time. However, it could be viral as well. And on the other side could be non-bacterial endocarditis, which is caused related to adenocarcinoma. And we mentioned the Lippmann-Sack endocarditis, which happened in patients with respiratory cancer and also systemic lupus erythematosus. Okay, so this question is asking about the rheumatic heart valve and also the valve replacement, they do have increased risk of infective endocarditis than any healthy patient. So these are not natural structures. So valve replacement, if you see, have a foreign body inside with increased risk of accumulation of bacteria inside it. Rheumatic heart valve, there is significant scarring, which gives space to the bacteria to accumulate in this area. So the answer to this question should go that the blood usually smoothly flows over the endocardial surface, but in rheumatic heart disease and valve replacement, there'll be lots of scarring that will, interfere with this process, and there'll be substantial scarring, and the inflammation will happen as well. The pathophysiology of rheumatic heart disease, to be honest, I wouldn't cover this area. It's not really relevant, in my opinion, despite feel free to read that. Okay. Again, these are some growth pathology for the scarred valve, and this is the dehiscent valve. You have dilated veins in here, and this is a removed tissue valve from a patient. Well, causes and risk factors of infective endocarditis. We mentioned some cardiogenic causes. If any patient had a previous myocardial infarction, or they have a valve replacement, or let's say previous infective endocarditis, or maybe myocarditis and the epicarditis as well, and also the we mentioned rheumatic heart disease or congenital valve disease as well, and maybe cardiomyopathy. So basically, any cardiac condition will increase the risk with different percentage. On the other side, if the patient has some sort of bacteremia, which could be due to UTI or any kind of sepsis, can increase the risk as well. Specifically, the IV drug users, they do have a specific risk and quite higher risk to have infective endocarditis, specifically on the tricuspid valve. The common organism causing infective endocarditis is Staph aureus, the commonest, Strep viridans, the second most common, and you have coagulase negative staph and the streptococci and the enterococci and the Hassig group, and this is Haemophilus species and the Aggregatibacter species and Campylobacter. The gold standard investigation for those patients is an echocardiogram, and they're basically trying to look for 1. Presence of vegetations, 2. Presence of any valve dehiscence, 3. Presence of an abscess or any accumulation. This will confirm your diagnosis, and we're going to talk about how to diagnose a patient now. So basically the story is, if you have a patient that you're suspecting they might have infective endocarditis, there are some parameters, but they are quite wide parameters. When we have so wide options for the diagnosis, we need to have a criteria. And our criteria here is Duke's criteria. You need 2 of the major criteria, or maybe 1 major and 3 minor, or 5 minor of the minor to say that this patient is definitely an infective endocarditis. So the major criteria are very objective, and these depend on the echocardiography, something that you can see by an echocardiogram, or the bacteria that you can see in a blood culture. So an echocardiogram, if you saw, like we said earlier, the vegetations, or you saw valve dehiscence, or presence of an abscess, will tell you, yes, there is definitely infective endocarditis going on here. Or blood culture, so if you have any of the typical organisms that can cause infective endocarditis, you will be happy to say, well, this is infective endocarditis. But blood culture need to be taken into 2 separate blood culture at 2 different times, and we're looking for a specific microorganism. If you find Coraxella burnetii, so that means the patient is mainly like very high chance they are infective endocarditis. We're looking for an abscess on an echo, or a dehiscence of the valve, or valve regurgitation, or presence of vegetations as well. The minor criteria, we talked about some of the risk factors, specifically the intravenous drug users and the rheumatic heart disease patients, and also prosthetic heart valve. New fever more than 38 degrees, or a few phenomena. You have something called vascular phenomena, and this is presence of an emboli or Janeway lesions, which are painless lesions present in the hand, or immunological phenomena such as Roth spots and also glomerulonephritis or Osler's nodes. I'm pretty sure that you know that. There may be microbiological evidence, positive blood culture that doesn't meet the above criteria that we just mentioned, or a positive echo that doesn't mean any of the above criteria that we just mentioned. So these are the minor criteria. You need 2 major criteria, or 1 major plus 3 minor criteria, or the 5 minor criteria. What are the complications of infective endocarditis? We mentioned some cardiac complications, myocardial infarction, pericarditis, arrhythmia, and so on. And non-cardiac will be glomerulonephritis, AKI, and stroke. The hand signs of infective endocarditis include Osler's node, Janeway node, and also splinter hemorrhage. What you need to know, Osler is painful, and Janeway is flat and non-painful. All right. Treatment, we usually give the patient antibiotic for 4 to 6 weeks, and that would be based on the culture and sensitivity. Most of the time it's gentamicin and vancomycin, ceftriaxone as well. In tricuspid valve, you need to think about heart failure, specifically right side heart failure. And if there is no response to the treatment, we need to do further intervention or heart transplantation. And we need to do HLA typing and APO typing before that. Types of graft rejection, you do have the acute and the chronic and graft rejection. And the acute one mainly happens due to HLA or APO system. And to decrease the risk of rejection, we need to give the patient some immunosuppressant medication that includes tacrolimus, myclophenolate, and the steroids. The side effects of long-term steroids, you can move into this now. So the way I remember the side effects is, I will start from the skin. So the skin, you can have is tria and delayed wound healing. The muscles, after that, you can have sort of muscle weakness. After the muscles, you have the bone. So the bone, you have osteoporosis. Okay. Inside, you have the blood vessels. That reminds me of hypertension. Okay. And also the fat surrounding the muscles. You will have truncal obesity, or obesity in general. The pancreas, that reminds me of the hormones. So patient can have diabetes from the effect of the steroids as well. Okay. Avascular necrosis in a bone as well can be mentioned, and can affect on the heart and so on. So as you can see, in the immunocompromise with opportunistic bacterial infection. The steroids are basically anti-inflammatory for the T-cell killer. Immunophilins are block the T-cell response. These are some sort of mechanism, but I think they're more related to part A rather than part B. We talked about warfarin. Patients on valve replacement need warfarin for life. And mechanism of action is a vitamin K antagonist, 1972. INR to monitor it. You can reverse it by vitamin K, fresh frozen plasma, or prothrombin concentrate. The last part is antibiotic prophylaxis in infective endocarditis. As per NICE guidelines, it's not really needed for dental procedures or for upper and lower GI or anything like that. The next part in the cardiovascular section will be femoral artery aneurysm. There was a male patient, non-IV drug user, HIV and HCV, multiple venipunctures in the groin, and now presented with groin swelling, bled 100 ml, and the bleeding stopped. What is the pathological consequences of venipuncture? Let's say if this is a blood vessel, you've done a venipuncture to them, that will lead to endothelial injury at the beginning. When this happens, that will lead to vasoconstriction due to release of vasoactive substance that will cause vasoconstriction, specifically thromboxane A2. That's what can cause it. After that release, the platelet role will come. The platelet will adhere to the endothelial cells with its normal function, and then will activate the mechanism or the coagulation cascade. The coagulation cascade, including the common and intrinsic and extrinsic pathway, will start formation of a fibrin-rich thrombus and that will stop the bleeding. So vasoconstriction is the main part in the beginning. The formation of primary platelet plug or plate plug formation, and then coagulation cascade activity with the common and intrinsic and extrinsic pathway to form a staple fibrin clot, which is the final product of this process. Two natural blood thinner medication, it's a tissue plasminogen activator and urokinase. All right? Type of HIV, this is an interesting one and quite difficult to remember, but I'll break it down to you into a few things. So the HIV virus is an RNA virus that is able to get the RNA inside the DNA of the host cell to help replicate in the virus. Okay, so it's a very smart way, and this is what we call by a retrovirus. So a retrovirus is the virus that is able to include their RNA into the DNA of the host cells to replicate their virus. So as you look here on this diagram, so that will explain everything. So the virus will have a capsule, okay, from the outside, and also something called nucleocapsid in the inside. Okay, so a capsule from the outside or an envelope, okay, and the nucleocapsid from the inside, or a capsid actually. So the capsid contains three enzymes, which are the reverse transcriptase, and integrase, and protease. Okay, and they will also have something called nucleocapsid, which contains the RNA of the virus. Nucleocapsid. So this cone-shaped thing is the capsid. Inside it there is the DNA or the RNA of the virus, and also three enzymes: protease, reverse transcriptase, and integrase. So we talked about the envelope from the outside and the capsid and the nucleocapsid, and in between there is the matrix of this virus. On the envelope from the inside there will be some sort of proteins, which are the pseudostructures like glycoprotein 41 and the glycoprotein 120. All right. So these are the structures of the HIV virus. You have the envelope, which is the lipid membrane taken from the host cells, and the glycoprotein spikes on that envelope. Then you have the capsid, which contains the three enzymes, the reverse transcriptase, the integrase, and protease. And then you have the matrix, which is a protein between the envelope and the capsid, and then the nucleocapsid protein lies inside the capsid and contains virus RNA. All right? Yeah, so these are the structure of the HIV virus. The patient started to bleed again, but the bleeding doesn't stop. So obviously the bleeding is coming mostly from a femoral artery. Femoral artery is high pressure. So increase that pressure can prevent the bleeding from stopping. If you read the stem again, the patient had multiple veni puncture. That can cause the surrounding tissue to be friable, and it will make it quite easy for the compression to work. Okay, so these are the local factors for failure to stop the bleeding. There are some systemic factors as well. We mentioned that this patient is an HCV and an HIV. HCV meaning that they are liver failure mostly, and they will have vitamin K dependent factors deficiency, and that's why they will have risk of bleeding with thrombocytopenia and platelet dysfunction. So always break it down into systemic and local factors. Approaching this patient, you need to wear protective clothes, and pseudoaneurysm, and how is it different from a true aneurysm. So in a basic manner, so the arterial wall, if we take like a closer look maybe in this area of an artery, so it will be formed of three layers: the intima and media and adventitia on the outside. So in an aneurysm, the whole three layers are weakened. So that will be sort of coming out like that. So this is an aneurysm. The whole three layers are weakened. But a pseudoaneurysm, you have an entry to the intima with blood tracking through the intima all the way up. So it will be sort of, this one is straight, and then suddenly you have blood tracking in here. So it will be sort of like this, and there will be blood accumulation in this area. So that's a pseudoaneurysm, would be a swelling to the outside, but there isn't any actual weakness in the wall of the blood vessels. An aneurysm is dilatation of the 3 layers of the artery. Causes of an aneurysm, the main cause is atherosclerosis. Infection is another cause, connective tissue disease, and congenital problems, and autoimmune vasculitis. Marfan syndrome and Ehlers-Danlos syndrome is something that is easy to remember and within to remember it. But the main cause, more than 90%, is atherosclerosis patients. Thank you very much.